Good morning. My name is Anita Arnold, and I'm happy to welcome you to the virtual Cardio-Oncology Summit. I'm very happy to be here, and I thank the organizers. My job today is to briefly review a case and highlight the role of advanced echo in cancer survivors. So I have no disclosures, and I have no financial relationships. So let me tell you about my case. Ivan is a very darling 17-year-old young man who initially presented with dyspnea at rest, exercise intolerance, and a cough. He had pericardial and pleural effusions noted with tamponade physiology, so he had those drained. Unfortunately, the cytometry of the fluids was positive for CD33 and CD45, which indicated a myeloid lineage. Flow cytometry excluded B cell and T cell markers, and his cytogenetics revealed a translocation in all cells, which indicated a malignant clonal process. Of note, bone marrow biopsy and aspirate were negative. He did have a pre-chemo echo, and for the sake of time, I'm not going to show you the pictures, but suffice it to say, he had normal cardiac anatomy. There was no evidence of congenital heart disease, no intracardiac shunting. The valves were normal, and his pericardial effusion had been drained. He had normal chamber sizes. EF was 60%, and unfortunately, they did not do strain at the time. He was treated with Children's Oncology Protocol AAML 1031. He had the induction 1 and 2, and then he had intensification, for which he was in the hospital the whole time. The total dose of anthracycline he got was estimated to be about 300 milligrams, which would be considered a moderate dose. He did have a CT scan after completing his therapy June of 2019, and that showed no evidence of disease. He did have serial echoes. The pediatric oncology team was following him about every 6 months with echo. He had one in January, I told you about, another one in April that was normal with a GLS of 21. In May, he had another one. I'm not sure why it was done a month later, but 62.3%. And then we saw him in December as he transitioned at the age of 18 into the adult cardio-oncology transition clinic. So I want to show you his December 4th echo, where he had a 50% ejection fraction and GLS was markedly reduced. So here you can see his heart rate is 96, his blood pressure is 112/58. And for those of you not used to looking at echoes, this is an apical long axis. It should be noted that Ivan is about 5 feet 4 inches tall, but 170 pounds, and his favorite pastime is lifting weights. So he has a very thick chest. You can see in the 5-chamber view the mitral valve towards the bottom, the aortic valve, and the left ventricular walls as noted. His strain also was abnormal. It calculated at minus 12.2. At that time, we started carvedilol. We talked to him more about diet and exercise, and repeated the study in a month. At that time, his images really did look improved. We have an apical 4-chamber view on the left-hand panel, and on the right-hand panel is an apical long axis that you just looked at. So at this time, his ejection fraction is normal, and his strain is minus 19.3, and his heart rate is 69, and his blood pressure is 108/76. So we continued to monitor him, but this was not a very good sign that he had a significant drop, even though he came back very easily with medication. So he had another study around 6 months later. He presented for routine evaluation, and although he and his mother said he felt fine, he had no concerns, he was doing well, we were a little distressed. His heart rate was 110. And his EKG showed sinus tachycardia. We decided to increase his medication and sent him for repeat echo. You can see this is not as good a view, but his heart rate is 110. This is the same 5-chamber view I showed you before, but his ejection fraction is clearly not normal, even though it's hard to see the endocardial borders. His strain also was minus 12.5. So there was significant concern that there was something untoward going on with him. Although he was asymptomatic, we made plans to do a little bit more testing on him. And unfortunately, 2 days later, he wound up about an hour south of us in Florida. He was in the emergency room with fever and myalgia and was tested COVID positive. He was actually admitted to another hospital about 2 hours away, and he was treated with IV IgG and 3 days of remdesivir. Unfortunately, at that time, he had a CT scan which showed a large mediastinal mass, which actually was encasing the aorta and the pulmonary arteries and putting a lot of pressure on his right heart, bilateral hilar adenopathy, pleural and pericardial effusions, and all three lobes of the right lung had parenchymal opacities, suggesting COVID-19 disease. The laboratory values he had showed a proBNP that was elevated as expected. Interestingly, his troponins were all negative. We actually thought at one point, looking back, that perhaps he had some type of COVID myocarditis, but that did not appear to be the case. His D-dimer, as in many of these cases, was markedly elevated. So he did have pericardial and pleural drains placed again, and his cytology was positive for myeloid sarcoma. He was transferred to our institution, and now his bone marrow was positive. So his diagnosis was recurrent myeloid sarcoma, now an acute myeloid leukemia. He was started on flag salvage therapy per the Children's Oncology Group as noted, and he slowly improved. It took a long time. He had a great deal of congestive heart failure. He required significant diuretic, which in association with his chemotherapy was a bit disconcerting. His creatinine stayed relatively stable, and he very slowly improved. Prior to discharge, we did do an echo on him, and although this shows that his right ventricle is significantly dilated and hypokinetic, the left ventricle was improved and did come back fairly nicely. His blood pressure was 109/53. The right ventricular systolic pressure was estimated at 42, which is not surprising. And his GLS was 21, although his ejection fraction was just barely calculated at normal. So you can see here before discharge, his echo pictures showing strain are pretty respectable. And so we were happy about that. But this patient is going to have problems in the future, no question about it. He currently is in the hospital now undergoing a second round of chemotherapy, and the plan is bone marrow transplant if he does well with this. So I just wanted to take a few minutes and discuss the harmonization guidelines for childhood cancer survivors. And this was a cooperative effort, as you can see, among several consortiums. And they tried to put together places where they definitely agreed and where they could try and harmonize guidelines for us to follow. So as with our patient, the incidence of heart failure will definitely increase with the higher doses of anthracycline. And it needs to be stated again, there is no safe dose of anthracycline. Survivors treated with anthracycline or with chest X-ray are at high risk of cardiomyopathy, and surveillance with echocardiography is felt to be a reasonable approach and should be lifelong. It's performed at a minimum of 5 years, but many groups use 2 years, and frankly, for our patient, we will be monitoring a little bit closer. A special comment about pregnancy: when these young women survivors become pregnant, there is a huge cardiometabolic demand, and closer monitoring is warranted. For my patients, I do within the first trimester and then before they deliver. Survivors with asymptomatic cardiomyopathy should be referred to a cardiologist, and survivors should be screened for traditional risk factors similar to any cancer survivor. So I have some references for you in the handout, and I wanted to thank you so much for allowing me to participate, and I hope that you enjoy the rest of the conference. I will be available by chat if needed to answer any questions you may have, and I hope you enjoy the rest of the conference. Thank you so much.